Hey, welcome back to another episode of Mind, Your Body, and Soul, the Healthy Podcast, the greatest health podcast in the world. I am Joseph Ward, and as always, I'm joined by the man with the plan, Mr. Matthias Sweet. How you doing this week, Matthias?
I'm doing good, Joe. Just, hanging in there trying to make it work. Trying to get caught up.
You know how we do. Working in healthcare,
No.
It's always something new. Remember, to all of our listeners, all of our viewers, and if this is your first time, welcome. Mind Your Body and Soul is an educational podcast that focuses on all things health related to help our listeners learn more about various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. And remember, Mind Your Body and Soul is available most time every Wednesday on our website at www.nmcpodcast.com, especially our NMC YouTube channel. So go to Neighborhood Medical Center on YouTube, subscribe to this channel, this video, like, comment, and share. And make sure you pull out your pen and your pad because you're going to learn a lot today. And remember, we're also available on Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcasts, and YouTube. So check us out.
That's a lot, Joe. That's a lot.
It's a lot. Hey, look, we are out here and we try to make sure we get as much information to people as possible.
I know that's right.
So I'm excited about this interview. This week we have Dr. Amanda Stevens joining us, and she is a board-certified OBGYN fellowship trained in gynecologic oncology.
Okay.
Originally from Southeast Michigan, she obtained her Bachelor of Science in psychology, shout out to psychology, with a pre-health concentration from the University of Michigan, Ann Arbor. Go Big Blue. She went to medical school at Lincoln Memorial University, the Butts College of Osteopathic Medicine, and in Harrogate, Tennessee. She completed her residency in this word always get me, obstetrics and gynecology through Beaumont Health in Farmington Hills, Michigan, and Gynecologic Oncology Fellowship at Advent Health Florida Hospital in Orlando, Florida. Specializing in gynecologic cancers, pervasive disease, and challenging gynecologic surgeries, Dr. Stevens has a special interest in robotic surgery and has been designated a robotic surgeon of excellence through the Surgical Review Corporation due to her high volume and excellent surgical outcomes. She is experienced in medical research and is a published author in outcomes of robotic surgery and endometrial cancer, contributing to numerous works in other gynecologic disease sites. She relocated to Tallahassee in 2019. Thank you, bringing all of your expertise to Tallahassee with her husband and 2 children. And she's working currently at Tallahassee Memorial Healthcare. And once again, all of our people, all of our audience out there in virtual land, put your hands together for Dr. Amanda Stevens.
All right.
Thank you.
Thank you for joining us.
Glad to be here.
Well, good. Well, Joe did a great bio on you because I learned a lot just from the bio because I'm already interested in OBGYN and robotics. I'm trying to figure this out.
Yes.
And you know I'm twerking. I've been watching my Chicago Med and stuff like that on TV, and I've been, learning about different little stuff. So I'm like, robotics and OBGYN. So I'm very interested now. It's got my wheels turning. So the first thing we like to ask, who is Dr. Amanda Stevens? And out of all the professions in the world, why did you want to become a doctor?
Wow. Well, it's funny because I get asked that a lot, and it's usually in the midst of a pelvic exam. And one of my patients says, why in the world did you pick this for your career? And it wasn't really on the short list of things I thought I would be doing. But admittedly, the pelvic exam is really just a small part of what we do in gynecologic oncology. I would say it was really a calling. Through my medical training, I was really drawn to this particular patient population. These are, women who have received a diagnosis that really turned their life upside down. And it's a special privilege, kind of sacred, if you will, to be able to walk this journey with them. And it's not always happy times, but it can be really meaningful in helping people meet their care goals, whatever that may be.
Okay.
Yeah, that's cool because I'm always interested when people take specialty routes like you do, because for one, it's something that you really have to develop specific skills and keep improving on your skill sets, because the field and things are going to change. Human beings, the anatomy isn't changing, but the way we're treating things and diseases and all those things are changing. So my hat goes off to you, because you're taking the route that I'm going to say a road that's less traveled. Most people don't grow up and say, hey, I want to be an OBGYN. Like you have the one out of school who wants to do that, but we need people like you to take in these paths. And the fact that you're not just on this path, but you're using your imagination and ideas to think outside the box of how you can treat these patients and really help people moving forward. So definitely hats off to you for that.
Thank you. Yeah, so gynecologic oncology is a subspecialty, as you referenced, from OBGYN. So gynecologic oncologists usually have 4 years of undergrad for their bachelor's degree, and then they'll do 4 years of medical school, and then OBGYN residency is 4 years, and then fellowship in gynecologic oncology is 3 years. So it really is a long road. You have to love it and be really passionate about these patients. That's right, it is a calling. But it's worth it.
So everybody listen up out there in the land. We need y'all to understand. Y'all need to go to school. It ain't that long. 10 years ain't that bad.
No big deal. My entire youth. It's fine.
Some of us spend 10 years doing what? Professional students. So you might as well go ahead and get something that's meaningful. You know what I'm saying? We do thank you and take our hats off to you for doing that special population, because we know as working in HIV, it takes a special person to work in special populations. Yes. And you got to be really passionate about it. I don't know if I could do your job. I'll
be your biggest cheerleader.
I'll cheer you on the sideline and be like, oh, that's how you do that? Okay, let's see. But I couldn't do that. Yeah, that's not something for me. But we really do appreciate you taking that time to come, especially in that specialty.
So and this is for our women who watch this podcast, and shout out to all the ladies who watch the podcast. How important, and I know for some people they may think this is a crazy question, but how important is it for women to receive their regular gynecologic care? The annual pap smear, the examination, and this is me as a guy who don't really know much about it.
Yeah, so, great question. It's a great question.
How important is that care, and how does the pap smear examination play a role in examining the overall health of the vagina or the whole area to be able to help improve the health?
No, it's a great question, and it's not a dumb question, because not only are there women out there that don't understand that, there are even people in our own healthcare profession that may not completely appreciate what it is that we're doing at these annual visits. I think it's kind of a soapbox of mine. I'm glad you brought it up. I think that it got a little confusing when our pap smear guidelines changed some years back. And now, so for some people, they might not need a pap smear every year. And so they may hear from their doctor, we've never had an abnormal one. We're not seeing the HPV virus. Your screen is normal. We can extend that interval. Some people 3 years, some people 5 years. But what's really important to know is your gynecologist is doing more than just a pap smear at your well woman or your OBGYN visit. So as you brought up, there are actually, several different structures in the gynecologic system that are equally important. To clarify, the pap smear is only screening for cervical cancer, cervical abnormalities, in effort to try to pick something up in its earlier states, as in the cells are becoming abnormal, even if it hasn't completely developed into a cancer yet. So you can intervene before a cancer actually develops. So even if you don't need to have a pap smear that particular year, your gynecologic exam is super important. The doctor is looking at the vulva on the outside. They're looking for lesions, because you can also have pre-invasive, meaning precancerous lesions or dysplasia, abnormal cells there. They're taking a speculum, looking inside, looking at the vaginal tissue, making sure there's no lesions there, making sure the cervix looks normal. And importantly, they are feeling on the exam, called a bimanual exam, because you're using two hands. One is usually on the inside of the vagina and the other's on the woman's abdomen or outer pelvis above the pubic bone there. that is oftentimes how a pelvic mass would be detected. If there's a bulge there, a density there, a mass there, or maybe the uterus is enlarged. These are all things going through the doctor's head well beyond the pap smear. So it's important that women don't confuse the recommendation that they don't need a pap smear for a few years. That does not mean they don't need a gynecologic exam. That should be done every single year.
Okay, that brings up a great point, because Joe probably know where I'm going with this. So in most of our classes, when we teach about STDs and sexual health, we always let the ladies know that just because you got a pap smear does not mean that you don't have an STD. Can you please tell them that they do not test for STDs in a normal pap? Those are tests that have to be requested. Because most people say when they get a pap that I got all my STDs and they said I'm good. So can you please break that myth down for us, please?
Absolutely. So your pap smear, the whole purpose is specifically to test for cellular abnormalities that lead to cervical cancer. Every once in a while, you might pick up something additional, but even so, you're supposed to confirm that with the appropriate testing. And yes, that is a different swab. And there's a whole panel of sexually transmitted infections that can be tested. Some are picked up with a swab or a culture vaginally. Some are a blood test. Some can be tested in the urine. I think it's really important that women be transparent with their care provider. It is a no judgment zone, and they can only help you if you are completely honest about anything that may, involve exposure to an STD. And really, if you are, sexually active at all, and especially with more than one partner or not using protection, these are conversations that are so important to have with your doctor, because absolutely a full panel of testing is important.
Right. Okay. I am glad you cleared that up for me and others, because in my mind, the pap smear, it was an annual examination that women had to take, and it pretty much told them the total health of the area. But that's just cervical cancer, but a gynecologic exam is what they would need to come back and get on the yearly basis.
Common misconception. Yeah, absolutely.
Cool, thank you.
So that goes to the next question is, what is gynecologic cancer? What causes it? And why is it bringing awareness yearly to the cancer very important?
So gynecologic cancer is a kind of an umbrella term, so encompassing several different types of cancers that are in the female gynecologic tract. So starting on the outside, you have vulvar cancer. So that's pretty much involving the external skin, and then also the mucosa, kind of the smoother lining just on the inside of the same folds. You can have vaginal cancer, which, as you would expect, cancer of the vagina, cervical cancer in the cervix, uterine cancer inside. So there are a couple different types of uterine cancer. You can get it in the cavity of the uterus, which is the area that sheds during a menstrual cycle, for example. Or you can get a less common subtype called a sarcoma. A sarcoma usually is affecting the muscle layer of the uterus, and there's a very slightly increased risk in patients who have fibroids, but still it's very, very uncommon, and it's something that should be followed with the gynecologist to determine if further workup is needed. And then you have ovarian cancer. The ovaries are inside the pelvis. The uterus and the ovaries a little bit harder to assess visually, of course, because you can't see them. You would need to do some imaging studies to see that, or go inside through an incision surgically and look at the abdomen. There are some other less common subtypes, for example, some that are associated with pregnancy. So these are all things that we are following and examining on these annual visits. And so it's important because, I think just in general, gynecology and really, any genital topic is going to be a little bit taboo. Like, these are things that, you're not talking about at the dinner table. So you don't know, grandma had ovary cancer. These things just don't really kind of come up. It's a lot more open now, but I think in prior generations, especially, it wasn't something that was widely discussed. And so it's something that not a lot of women are really aware of. And it's important. That's why it should come up at these visits, and it's important to make those visits so they can be discussed, because everyone has, potentially slightly different risks based on their history, their exposures, and their family even.
Right, because you brought a lot of clearness to that for me, because I didn't know that the vulva and the like the
labia.
The
the
vagina
labia,
and the
major,
vulva.
and minor, all them
I
can get
learned that.
cancer.
So, right.
When you say like, oh, they got uterine cancer, you just think the uterus. You don't think nothing else of there's different pockets. And then I didn't know anything could happen to the outside. I just, you know what I'm saying? So it's just like learning about that's fascinating because it's like, wow, all this could happen.
Right.
Like
Lots of different components. Yeah.
yeah.
But also speaking about components, the components of the total area, because now I don't want to just say the components of the vagina because that's a specific area of it.
Correct.
Right.
Yeah. And a lot of women will refer to the vulva as the vagina. It's not.
Right.
The vagina is on the inside.
Right. But that's important because if you have a person that's trying to explain specifically what's going on to them and they continue to use the word vagina, and so the person may think they're actually talking about the actual vagina, but she could be talking about her cervix, she could be talking about a labia or something else. So that's important.
The ovaries, all that.
The exam is important for that reason. And, and eliciting some of that history is helpful. I don't want women to feel bad about not knowing, the anatomic terms, and that's okay. But I think it's important that, we have an actual exam so we can get very specific about what's the problem area.
Right.
I have another question. So during that exam, is it painful for the females, for the young ladies? Is it painful, or is it, if it's painful, does it mean something's wrong, or like what should a person like kind of expect in that? Because
yeah, that's a good question. I can honestly say it's rare that I have a patient that says the exam is painful. That being said, I probably do 100 of these a week. It's a weird thing to say out loud, but that's my job. Some women can have some discomfort. So things that might make it a little bit more uncomfortable is, for example, after menopause, there's not as much lubrication in the vagina. Estrogen kind of plumps up those cells. And so, for example, I might use a smaller size speculum in those patients and a lot of lubrication really on pretty much every patient. It's different for everybody, but it doesn't have to be uncomfortable. It's very rare that it's absolutely intolerable. I don't find that often, at least not at my office.
Okay.
That's a good question, though. That is.
No, definitely.
Yeah, because we don't have a vagina, so I couldn't tell you. I never had a pap, so it's just like.
That's a good question. Yeah, absolutely.
Like, yes.
If it's all going in there, like, is it okay? Is something wrong? And just trying to make sure that what I'm saying.
It does not mean something's wrong necessarily.
Yeah.
I got another question. See this stuff.
Good.
So for members of the LGBTQ population who happen to be the lesbian or the stud or the more masculine type men, is it important for them to also get pap smears? Because I know a lot of times it's hard for us to get them in to get those regular female things because they do feel like they are more masculine and more male oriented. So I just don't know, how can we, do you face that in the clinic that you're in, like issues with that population on how can we get them? But it is important for them to get those exams still.
It is. So, and everybody might be on a different stage in that transition, so to speak. But I think it's important, if you currently possess those organs, that you should have them followed, because, just because you're taking testosterone or just because you identify as the opposite gender does not lower your risk of getting a gynecologic cancer if you do currently possess those organs. And that's something that we don't face a whole lot in the oncology world. Every once in a while, we might have a patient in those unique circumstances, but certainly in the OBGYN population, or kind of your more general OBGYN offices. And that's something, that every doctor should be really comfortable with dealing with. A person should not feel, embarrassed or question, will I be, accepted? At least I can speak for myself. I treat every patient as equally, important. Their concerns are valid. Their health is my priority. And as physicians, that's the oath we took. And so they should not hesitate coming in to get that examined, because they're just as, possible that they could get a cancer as long as they have those same organs. It should be checked. Absolutely. Same recommendations.
Okay.
Appreciate that.
Yeah.
So I want to ask this kind of a two-part. What are the most common forms of gynecologic cancer, or does a more common form exist? And what are the more aggressive forms of the cancer, and how are those aggressive forms identified?
Yeah, that's a big question. So the most common type is going to be uterine cancer. Uterine cancer, and more specifically endometrial cancer. Now, you might hear those synonymously. The endometrium refers to the innermost cavity of the uterus. And it's going to usually occur in the kind of later decades of life, usually after menopause. The big takeaway that I want women to know is that essentially the definition of menopause is you have gone over 12 months with no period. The average age of menopause is about 50, 51. And so if you have surpassed that age and you have gone 12 months without a menstrual period, you're very likely menopausal. Your period should not restart after that. So if you experience vaginal bleeding after that point, it must be evaluated by your doctor. There's no such thing as one last hoorah. You know, there's not going to do something, my body just wanted one more period. Every time, get that checked out. It might not be cancer, but you should absolutely get that checked out. That's the number one symptom of endometrial cancer.
Okay.
You know, ovary cancer is another big part of what I do in our clinic. And what's hard about ovarian cancer is, unlike a lot of the other gynecologic cancers, there's not a great screening test for it. This is something that's been extensively studied, and unfortunately, we don't have a great method for diagnosing or predicting when somebody's going to have that. So, for example, with uterine cancer, like I said, almost invariably the woman's going to have postmenopausal bleeding after their period stop. For cervix cancer, most of those are going to be picked up on pap smear. You know, the vulva, vagina, that's something that might be visualized at the time of your exam. But like I mentioned earlier, the ovaries are inside the pelvis. We can't see them with our eyes. We can't swab them. We're a little limited in what we do. And so in addition to that, the symptoms of ovarian cancer can also be kind of vague. And so I would encourage women to always err on the side of discussing with your doctor. It might be nothing, but if it's something, we don't want to miss it. And oftentimes, you know, that might be followed up with an ultrasound, looking to see what those pelvic organs look like. And for most women, that's not painful, or a CAT scan. And there may be a blood test that can help us discern the importance of a cyst or an enlarged area on the imaging study. For ovarian cancer, like I mentioned, the symptoms can be somewhat vague. Women might have pelvic pain, or they might not. But I always say, if it's this kind of persistent or nagging pain and it's not getting better after a bowel movement, because constipation can also kind of have some of these similar symptoms, then you should get that checked out. Bloating is a very common symptom of ovary cancer, and and unfortunately, a lot of women aren't going to develop symptoms until it's in later stages. And of course, prognosis is not as good when it's diagnosed in later stages. Not to say that it's not treatable, but it's a bigger job. And so the later stages are the belly kind of filling up with fluid. And so if you feel like, gosh, my belly's filling up with fluid, or I'm feeling more distended, I might be having some discomfort. I notice when I'm eating, I might take a few bites of food and I get full really fast, when you know you haven't eaten enough for that to happen. That's called early satiety. That's something that should be absolutely checked out. Or, when you're having weight loss, but you're not really trying, it's unexplained, or, intentional weight loss, and you haven't really changed anything. These are things that should be evaluated.
Okay. So, a question popped in my head because you were talking about menopause. Because you're talking about not having that surprise period after menopause.
Right.
So with that being said, how does, and this is a bit off the beaten path, but how does some women after menopause, how do they still get pregnant?
Well, in theory, they shouldn't.
Right.
Help from a specialist in the reproductive office, but no, they really shouldn't. So your periods are usually in response to ovulation. It's a whole hormonal fluctuation that is basically triggered by ovulation. So the ovary is releasing an egg. The egg travels. If it gets fertilized, a pregnancy develops. If it doesn't, then the lining that was being prepared inside of the uterus will shed. It looks like blood, but it's actually endometrial tissue. It's just the lining is thinning because it didn't need to support a pregnancy. So in theory, if a woman is after menopause, they shouldn't be releasing eggs, and so they should. In theory wouldn't be possible, but there's probably a crazy story out there. I don't know. Maybe around the time. Maybe they weren't really menopausal. I don't know.
Gotcha.
That brings on another question for me as well. Like when you see because some of my friends, their periods, they be 2 to 3 days, some 7, but then you hear those stories, I've been bleeding for a month. And like then they come to the doctor and you be like, what made you come why you didn't come earlier? Like if someone's period goes longer than 7 days, if I think that's the normal time frame, should they seek their primary care, or should they automatically go to like an OBGYN, or what's the steps of that, just to be proactive?
Yeah, good question. I mean, periods come the whole spectrum. There's all kinds of variations. Some women it's short, some women it's heavy. It should be pretty regular though. So whatever is typical for you, you should expect that that's going to happen essentially every month. So if you're experiencing prolonged bleeding, then yeah, I would have that evaluated. Or if you are having all of a sudden 2 periods in 1 month, it may not represent cancer, but another common thing that we deal with, for example, is uterine fibroids, and that may lead to heavier bleeding, or there might be a polyp inside of the uterus. I think too, what surprises me sometimes is how long women put up with heavy bleeding. I mean, if you are saturating like a peri pad, like your standard, pad for menstrual cycles in an hour, and you're having to change that every hour, that is too heavy. If you are soaking through a tampon and your pad, that is too heavy. And these are things that you can tolerate for a short amount of time, but if that's happening to you every single month, you're going to become anemic. Your blood counts are going to drop, and you may get dizzy and even pass out. And a lot of women, because this has been so chronic, they don't have a lot of symptoms. Their body has learned to kind of tolerate this lower hemoglobin. So that may not necessarily be a cancer situation, but it can absolutely be helped. You can eat whatever somebody is comfortable with. There's, especially in, our region in the Panhandle of Florida, there's definitely not a lot of people that do what I do, like the gynecologic oncology, but there are several options for OBGYNs. And then there are a lot of family doctors that will also do gynecologic care. And I think that's just a conversation that they need to have with their primary doctor. Is this something that you're comfortable managing? Do you feel like I should have an evaluation by an OBGYN? Because that's bread and butter for them. It should absolutely be something that they can manage. But yeah, there's no reason that you want to, suffer at home. Let someone know what's going on.
Right. Well, that kind of goes into like the next step is like you told us about the most common gynecological cancers. I'm gonna get it now.
Right?
And and their aggressiveness. But how do you treat the gynecologic the word cancer?
You can say
cancer.
I know.
And like how you treat it overall, and is there a more aggressive form of cancer that needs to be treated, like different treatments and things like that? So how do you treat the cancer?
Oh, so it depends on the cancer, and it also depends on the stage that a patient has at the time that they're diagnosed. So I'll speak about, uterine cancers or endometrial cancers. So the vast majority of those, because women will often start having bleeding and that triggers, a doctor's visit, those are often diagnosed, thankfully, in earlier stages. As long as they seek treatment promptly, evaluation, and many of those can be treated by surgery alone. The way we determine if a patient would benefit from additional treatment, such as chemotherapy or radiation, really is established by their stage. And stage of a cancer is, for most of our cancers, determined surgically, meaning we can't really say definitively what someone's cancer stage is unless we do surgery to take out the tissue and we look at that under the microscope, because it depends on what areas are involved. One of those areas that we look at, of course, is the lymph nodes. Lymph nodes travel along the lymphatic system, travels with our circulatory system. And when you look at them just intraoperatively, they kind of just look like little fat pads, and they have these kind of little pearly round structures inside. And those are the lymph nodes. We have them through our whole body. But specifically for our gynecologic cancers, usually if those are going to leave the organ where they started and go to the lymphatic system, we might find them down in the pelvis, which are kind of like on the side walls of the pelvis or higher up in the abdomen there. So part of our staging surgery is removing some of those lymph nodes so our pathologist can look under the microscope and let us know what's involved. So whether, you know, someone might need additional treatment really depends on what stage, because if the horse is out of the barn, so to speak, you do need to be a little more aggressive with your additional therapies in order to reduce the risk of it coming back. So that's the main one. For most ovarian cancers, that we will recommend chemotherapy, and that's part of the package. So surgery and chemo are very popular for that one as far as a treatment plan goes. There are some circumstances where surgery alone would suffice. For our other cancers, it really depends on again, what the stage is. So cervix cancer especially, so this is a question I get a lot. So for cervical cancer, it kind of spreads in a slightly different pattern. So all of our cancers have a tendency to spread in their own fashion. And cervix cancer, when it starts in the cervix, it likes to kind of spread outward or laterally. Well, we're a little limited surgically in how wide we can go when we are cutting, so to speak, around the cervix. And so when a cancer gets to a certain size in the cervix, surgery may not be an option, or at least not a good option, because patients might have a lot of serious surgical complications. But also it really doesn't improve their outcome unless you can get all of the cancer out. And so if I can't get all of the cancer out because it's too big and I'm going to end up leaving some behind on the margins, the treatment of choice is going to be, again, chemoradiation. So it's primarily radiation, typically with a low dose of chemotherapy that helps it work better.
Okay.
It's different for all of them. It's a little complex. It just depends.
Right. And but I'm glad. Thank you for answering the way you are, because you keep reminding us that there are different components and there are different cancers for the different components that are going to take the different treatments, rather than us just looking at it as a whole. So
Right.
I think it's a big question I always get is, you know, like, especially for our cervix cancer patients, they go, well, why can't you just cut it out? And it's so hard to explain, like, yeah, you have something there. And my instinct too would be like, oh, let's just take it out, but it doesn't help. And that's one of the hardest things to explain to patients. And I just think, again, just having the open communication with your doctor, and usually I can explain that with a diagram, which I don't have here today, but that'd be helpful to show you what I'm talking
But with
about.
the even with the surgery though, because you don't want to take it out, because then that causes with the hormones, am I right, where it produces hormones and things like that, but they have to be on certain medication.
So the hormones are specifically secreted by the ovaries.
Okay.
And so, you know, just treating a cervix cancer may or may not affect that, especially in some of our younger patients. So meaning pretty much anybody that's not menopausal yet, they may be a candidate to leave their ovaries in, for example, even if you're taking out the uterus and cervix, or even if you are doing radiation, there may be ways to protect the ovaries so they can continue making hormones for the patient.
Okay.
In some cases, when that's not possible or not advisable, hormones can be replaced if a woman, you know, is having symptoms from their early menopause that was induced by either their treatment or their surgery. Sometimes those can be replaced. Now, that's not possible for all disease sites or in every single situation, because actually some cancers use hormones as a building block to grow and to multiply and spread or recur. And so in some situations, it would be better to use non-hormonal options to help alleviate some of those symptoms as far as their cancer is concerned.
Okay.
So you talked about some of the limitations in the surgery. So this is where, well, I'm curious about the robotic surgery coming.
Yeah.
But before I get to that question, how did you get interested in robotic surgery?
So it's really, in my opinion, like not even possible to not be interested in robotic surgery. It's changed the way that we operate in so many different aspects of surgery, but especially in gynecology and especially in gynecologic oncology. I'm just thankful. I kind of came through at the right time in my training. So robotics has been around for a while, but back when I was in residency, maybe like the 5-10 years before that, it was, brand new. Da Vinci came out with this cool machine, and maybe I should just stop for a moment and explain what the robot is.
Yeah.
Because I've had patients say, well, what do you do while the robot's doing my surgery? Like, I go get breakfast. But no, that's not really what it is. So it's neat. So probably most people are familiar with basic laparoscopy, small incisions on the belly and these long instruments. And I kind of joke, it's kind of like Edward Scissorhands. The business ends down here, and maybe you have good control if you have a nice steady hand, for example. But some of the areas I'm working in are very intricate. They're high risk areas, right on some blood vessels. You don't want to worry about a tremor. You don't want to worry about, can I reach around that vessel to get where I want? So the robot is really made to emulate human hands. It has wristed instruments, meaning instead of just this long straight instrument, these are flexible. They have a wrist, they have graspers. And so when a patient has robotic surgery, I place very similar ports, also called trocars, in their belly, which are kind of like, tunnel, like cylindrical instruments that go in through the incision into the belly. And then the robot is this kind of big structure that has docking sites. So when I dock the robot, I am connecting the robotic device to the ports in the abdomen. And so then I am actually in another part of the same room on a console. And I kind of grew up in the video game generation, so I love the console. It's really slick. So you put your face in this eyepiece, and it's 3D. It's combo 2 different cameras that essentially make you feel like your face is inside of their abdomen. The optics are really good, and so I have little hand pieces that help me to direct what I want the robotic instruments to do real time, of course. And it even gives me an option to have a third arm inside of the patient's abdomen. So I very commonly will do that because I can retract tissue for myself. And of course, I only have 2 hands to guide it. So one is always stationary, but I can shift between or clutch between the 2 different arms, the 2 that are working. And then if I decide, okay, then I'm going to clutch and I can now move these 2. Well, this is holding something for me. So it's kind of like being the surgeon and your own assistant at the same time. So that is usually how the robotic surgery works. The way it was developed, it's improved patient pain outcomes, so less post-operative pain, and therefore shorter hospital stays. And a lot of times I have to tell patients, like, I know you feel pretty good after surgery, but you had a major surgery. Don't overdo it, because they snap back so quickly. One of the cool features of it that I like and feel probably contributes to the lower pain is that when you are doing kind of general laparoscopy, and if this is the incision and you have an instrument through the port and you're trying to reach things in the pelvis, you're going to get a lot of tugging at that incision site. But the robot is actually specially designed to make a fulcrum right at the skin. And so it's going to rotate on a fulcrum there, therefore reducing the tugging and trauma at the abdominal wall, therefore less pain. It's really changed the way that we do a lot of our surgeries. Patients are able to go sooner with less pain.
Right. And so it has helped you guys to be able to perform more gynecologic surgeries as far as treating the cancers, and just be able to be a lot more proficient with your surgeries.
Exactly. Very fine movements, no tremor. And so when I'm taking lymph nodes off of a blood vessel, those small movements matter a lot. And so it allows us to be very careful and deliberate.
Right. So, and just, I know I'm dating myself and probably but I'm thinking about the game Operation when we were young, and you had to be careful not to touch the sides. But so to eliminate my shaking hand, right, my hand was always shaking. But so to eliminate that, use the robot who is steady and has the same range and flexibility. That's so cool.
So the training process is very regimented. So you have to go through a very specific process. So sorry, I started kind of explaining, like, when I went through my training, about the decade before me, my trainers were just being trained. And so it was such a novelty for them. And so, part of your residency or any of your training is to be a part of these surgeries, learning to assist in the surgeries, and then eventually perform the surgeries under your trainer's guidance. But you know, when this is the new hot commodity for your trainers and they're still learning how to use the robot, you know, those residents maybe don't get as much time. I kind of came through at the sweet spot where, you know, it wasn't such a big deal anymore and they were very comfortable with it themselves. And so when I came through residency, I started very early on. You start with kind of you have to understand exactly how the robot works, what all the buttons do, what kind of energies it uses, how do you troubleshoot any issues, how do you keep the patient safe? And then you must assist on so many different surgeries to show that you know how to troubleshoot anything patient side. Even with the robot, I'm never doing surgery by myself. I rely on my team that's specially trained in each of their roles, and that's very important to have a cohesive robotics team. And so I have, you know, my PAs, for example, might be at the patient's bedside. They may be switching out my instruments. They may be putting a suture inside the belly so I can sew something up. I have my surgical technologist who's handing the instruments over. She may be cleaning the camera. You know, all these players play a, you know, a really important role, and it has to work seamlessly in order to keep the patient safe. So everyone on that team has had extensive training on, you know, all the way from how does the robot work to ultimately how do you perform the surgery.
Now that sounds interesting. Many hours. That stuff I really want to see in person, Joe.
Yeah.
That kind of stuff you really want to see in person because you hear about it and you read about it and you be like, really, a robot is gonna do this out? Or like, I think my mom had her gallbladder or something out, and they went in with like the little scope and bloop, and that was it. And I was like, you don't get the big incision no more, or
it's a whole ball game. You're not in the hospital for a week after a hysterectomy. It's totally
That's
different.
great though.
It really is.
That's real good. So robotics is where it's at. So now I know next time if I ever have to have surgery, use the robotics, please.
It definitely depends on what you're having done. There are certain things that can absolutely be done laparoscopically. It might be overkill, you know, it's for something small. But, you know, I'm glad you mentioned that because there are actually some surgeries that should not be done robotically. And, you know, along those lines, some of our ovarian cancers, for example, we might not necessarily do robotically. So there are, you know, anytime someone has a large mass in the pelvis, like I mentioned earlier, we don't know for sure until it's already out in pathology looking at it under a microscope the significance. So we have to assume more or less that every mass we see could be a cancer. And so what's important is that you don't rupture a cyst inside of the belly when there's that suspicion, because if there's a cancer that's contained inside of an ovary and you rupture it, well, that cancer can then spread throughout the belly where all this previously contained fluid has now spilled. And so if a woman has a very large cyst, there are still some you can do robotically as long as you can contain it in a bag. And then the bag can be taken out at the edges at the abdominal wall where the incision is. And then it can be ruptured as long as it's contained in the bag and it's not going to spill in her belly. But for some, there's just no way to fit that out safely. Or for a large uterus, for example, if there are fibroids, it's actually no longer recommended that doctors grind up fibroids inside and pull them out through small incisions. So if that can't come out in one piece, it's really not recommended to do it that way. We want to make a bigger incision to take that out. And that's because of the very small chance in a woman with fibroids that there could be an underlying cancer. This kind of came about several years ago where the morcellation was actually a pretty common practice. Morcellation refers to kind of the grinding up, if you will, of a fibroid uterus. Well, if you're the 1% chance risk of a cancer inside of one of those fibroids and we've just ground it up and there's pieces flying everywhere and we're trying to pick those up and pull them all out, then you've effectively worsened that patient's prognosis. And so always, you know, choosing the right candidate for robotic surgery is important. And it's really an individualized conversation with your doctor about what are the circumstances at play here. How can we do this the safest? Patient safety is always, you know, our primary concern.
Well, that opened my eyes to a lot because I'm just happy that it's changed from where it goes. So like when I see my daughter, if anything happens, I know I can see those kind of things and things like that happen. So that's good. So my other question is, what makes a woman more susceptible to develop gynecologic cancer?
Oh, great question.
I'm gonna get it right one day.
I'm impressed, yeah. So again, it depends on what kind of cancer. So Something that maybe a lot of women or people in general don't know is that, like I mentioned earlier, some cancers are hormone receptive, meaning they might be fed by hormones or they may grow when exposed to hormones. Now, endometrial cancer is one in particular that might fall under that umbrella. Again, that's the cancer inside the uterus. So we might see that in women who are taking hormone replacement therapy if it's not balanced with a progesterone. Estrogen can serve to thicken the lining of the uterine cavity, and when that goes unchecked or it gets too thick, a cancer can develop. And so when there's an abundance of estrogen on board and this happens, that it needs to be stopped, or you need to intervene or find out what's going on in order to reduce her risk. Now, the other place, a lot of people don't know, but the other place besides the ovaries that estrogen comes from, or besides replacement, whether a pill or a patch, is actually our fat cells. This is sometimes a hard thing to talk about because you don't want to make anyone feel bad, but you want to help them and reduce their risk of uterine cancer. And a lot of our estrogen comes from our fat cells. And so it is more common, or it is a risk factor to have obesity when it comes to uterine cancer, many cases. And that's again because estrogen is converted in our fat cells in our body, or it's converted to estrogen, and that can stimulate the lining of the uterus. And so anything that somebody can do to, develop a healthy lifestyle and lose that weight can be beneficial or protective when it comes to uterine cancer. Some of our other cancers, like ovarian cancer, for example, now the vast majority of these are just going to be bad luck. This is just a sporadic thing that happens. Really, all cancers are bad luck. It's not, it is not, you didn't get cancer because of something you did. It's not your fault. These things happen. But some ovary cancers can actually run in families. And it's something that you will often see in multiple different generations of a family. So, just because, great-great-aunt Betty had ovary cancer, it doesn't necessarily increase your risk. But if you're seeing it in pretty much every generation, like mom had it, or, her sister and grandma and my cousin, that may be related to a genetic issue that predisposes someone to getting ovary cancer. And there are also sometimes other cancers that are also in families that are linked to that syndrome. Breast cancer in particular. So if you're seeing breast cancer and ovary cancer in somebody's family tree, that is definitely somebody who's a candidate to have that worked up. And so how that works is really anybody can make the referral. So a patient can go to her primary doctor, you can go to your gynecologist, you can come talk to me, but we would review the family history in light of what's going on with the patient, and we may make a referral for genetic counseling. Ultimately, it comes down to a test to find out if there is a mutation in the genetic code that is leading to development of these cancers. Sometimes it raises an ethical question. So, that's why I always send my patients to a counselor who can really take the time to explain their risks of anything that might be related to that, because, some people might not want to have that information. I'm, in general, though, a big proponent of genetic counseling and having that information, because there is an opportunity to intervene before someone develops a cancer. So, for example, all of my ovarian cancer patients are offered genetic counseling because if they harbor the most common genetic mutation, again, most are sporadic, but if it's genetically linked, the most common is BRCA, or commonly called BRCA. A mutation in BRCA1 or BRCA2 gene, then they're also at increased risk of developing breast cancer. So if that's not happened, they have an opportunity to reduce their risk of getting that. And that may involve surgery, or that may just involve more frequent imaging to find out if there's anything brewing, or to catch it earlier if there is. And it may also be good to have that information if you have any family members. What's also important to know is that I have patients all the time say, well, I only have sons. Well, your sons can pass that on to their children. And the other cancer that's linked to this is prostate cancer. And so even, the men have a role in this. And so it's something that we'll talk about, usually just based on someone's family history.
Okay.
So I got another question. I always like questions.
Go ahead.
So when young girls start taking birth control, and you say that a lot of the cancers can fuel off of hormones, what do we need to do if that is the case, or how do we know if somebody's going to be able to fuel off? Is it a good
Yeah.
idea to put them on that, or is
Yeah.
there one less or not? So
Yeah, so it gets a little complex, and in actuality, the ovarian cancer risk is decreased when women take birth control. So it's a little confusing, but when somebody is on hormones, you want it to be balanced. So estrogen and progesterone want to be in harmony. And so the uterine cancer risk I was referring to earlier is when there's an abundance of estrogen relative to the progesterone. In fact, one of the treatments in certain candidates for endometrial cancer is to replace the progesterone to get these back into balance. And that can actually thin out the lining and reverse a cancer or precancerous condition. Not in every circumstance, but some people, they may be a candidate for that. But the way birth control works is actually to inhibit ovulation. Generally speaking, anything that is going to reduce a woman's lifetime number of ovulations actually reduces their ovarian cancer risk. And so taking birth control, oddly enough, being pregnant, breastfeeding, these are all things that are inhibiting ovulation. And so it actually may decrease their ovarian cancer risk. Morgan and I were actually just joking before this podcast about that. Does not mean you should stay pregnant and have a baby every year.
Right.
It's maybe not the most effective way to do that. I think you do you. I mean, but no, birth control can be very safely used.
okay.
You just reminded me, because I don't remember where I was, what I was listening to or whatever, but it was talking about women who like go into their mid to late 30s, even to their 40s, have a higher risk of developing the cancers because they haven't had children, rather than the women who have had children. That's okay. Okay.
Yeah, I mean, the absolute risk is low. It doesn't significantly raise their risk,
Right.
but again, you know, they've had more years with periods, and so that's essentially why that's linked.
Yeah, exactly. And genetic counseling, I never heard of it, and I never thought about genetic counseling. But so is that one of the main treatment paths you all use for gynecologic cancers, or even ovarian cancer, or the other types of cancer? So well, let me restate this. In addition to the genetic counseling, what other prevention methods are being used?
Yeah, so the genetic counseling is mostly just going to be for your ovary cancers and some uterine cancers. There are some uterine cancers that may be related to that, and there's a whole different syndrome that's related, colon cancer, for example, and uterine cancer. So it ends up being kind of a specific conversation with your doctor about what your risk factors are. But the primary genetic basis is going to be ovary. Fallopian tube also goes along with ovary. Fallopian tube and ovary cancers they essentially come from probably the same origin. There's yet another one that I didn't mention earlier, but it kind of acts in the same way, and it's called peritoneal cancer, and that's basically the lining of the abdominal cavity. It's called the peritoneum. So we sort of use them, even refer to them synonymously. So peritoneal, fallopian tube, and ovary cancer, because they're almost always the same cell type, and they kind of come from the same embryologic origin. So that one is more so genetically linked. The other things, in order to reduce risk of uterine cancer, so if you're postmenopausal and you're taking hormones and you have a uterus, make sure you're getting progestins with your estrogen. Never just take the estrogen unless you don't have a uterus. It shouldn't be used in isolation. And testosterone is not the counterpart to estrogen, despite my popular belief. So if you're seeing a hormone specialist and they got you on estrogen and testosterone, you better make sure that you also have some progestin in there to protect your uterus. Definitely a healthy lifestyle can reduce risk of uterine cancer. Obesity is an independent risk factor for developing uterine cancer, like we kind of alluded to earlier. So healthy diet, regular exercise, normal BMI, body mass index, can reduce your risk. It doesn't mean it completely takes it away. I also have patients with normal BMI that get uterine cancer, unfortunately, but that is something that can reduce your risk. Cervical cancer, and so cervical cancer, vulvar cancer in particular. Now, these are oftentimes related to the human papillomavirus, HPV. And so for that, screening is really important, but on the behalf of the patient, taking precautions to prevent contracting the human papillomavirus can reduce your risk. So condom use, really important. Anything that's reducing the exposure, among all the STIs, but this one especially because it can cause cancer. We're really want to stress that. And then again, your regular screening, whatever that may be, as discussed between you and your gynecologist, that is really, really important as well. Cancers can develop in it doesn't play by the rules. Every time you try to think you can define it, it surprises you and it acts completely differently. But, it can develop in short term. The way that the screening is developed is to be able to catch it before it becomes a serious problem, because there are so many steps along the way where you can take action to prevent it ever getting from the actual cancer end of the spectrum.
Right.
So keeping, doing healthy things to keep your immune system as strong as it can be. Don't smoke, quit smoking. That is a big one. It's almost invariably when I have a patient who cannot clear the human papillomavirus, they are a smoker, and they already know all the other, health reasons why it's not good for them. And believe me, I know, easier said than done. We talk about this all the time with patients, but quitting smoking can have a significant beneficial impact on risk of cervical cancer and vulvar cancer. Some patients are candidates for vaccination. In fact, most of our young people, pretty much everybody after my generation, is candidate to have vaccinations. So talk to your doctor about that. Am I a candidate based on my age, based on my exposures, based on my history? There are actually many, many different types of human papillomavirus subtypes. So there are some that cause cancer and some that don't. Some cause warts, some are cancer causing. And so the vaccines that are out now will cover several different types of strains. And just because you're not having, say, like vaginal intercourse, you can also get HPV infections of the mouth, throat, from oral sex. And so these are, it really behooves you to reduce risk in any way you can from getting that exposure. Now, you can clear the human papillomavirus.
Right.
It's very, actually, so in younger people especially, and this really kind of led to the change in the guidelines for Pap screening. So we don't screen people less than age 21 anymore, because they have, our youth has such robust immune systems that the majority of the time they're going to clear that virus without any intervention. Used to be, you Pap a 16-year-old and okay, they'd have HPV or abnormal Pap, and you do this whole workup and you take out a big chunk of the bottom of the cervix, and then they'd have problems getting pregnant, or they get pregnant and they can't hold the pregnancy in. Your cervix does not regenerate. The cervix you have is the cervix you're going to have. And so if somebody's going to be planning a pregnancy, you need as much of that cervix as you can. It could still be done safely in the appropriate population, but the vast majority of our young people are going to clear that without our intervention. So we start screening at age 21, and then anything that you can do to, boost your immune system, easier said than done. But again, a healthy diet, regular exercise, adequate sleep, stress reduction, all things I need to be telling myself. But it's really important for everybody. I know it's kind of a blanket statement, but quitting smoking, that's a big thing that can really help with that.
Right.
That's a lot.
There's several mini lectures. We should probably do a part 2.
We down for that, so it's okay.
Yes, we're gonna set that up.
Question. So with the gynecological health services, what services are here in Tallahassee for people who are in search for gynecological services? Where do you find these services at?
Yeah, so on our website at TMH, you can search by specialty, and it's going to list all the different OBGYNs. usually you're going to start with your general OBGYN, and they can manage the vast majority of gynecologic needs. And my subspecialty which is gynecologic oncology, is really more geared toward cancer or concern for cancer or risk of cancer. So absolutely make a connection with an OBGYN, and they can help kind of assess your risk and manage any issues you may be having. It does you have to get creative, when, for example, somebody doesn't have insurance or their insurance doesn't cover everything that needs to be done. Still, please be seen. There are resources that are available to help women get the care that they need. And so don't let that be a roadblock. Start with our website. At our cancer center, we have actually a lot of different services, and we also have a foundation in place to help those who don't have the means and really need the care. We currently support several patients in different ways, whether it be paying for their chemotherapy or their immunotherapy, or even getting CAB vouchers when needed, getting people to the treatment that they need. So don't let that be a roadblock. Our social workers and our cancer center navigator team can help people get connected to get insurance, to get Medicaid, to make connections that they need in order to support their health, because early prevention is key.
Right, and for all of our viewers, our YouTube viewers, there's a link to TMH for the different gynecologic services in the description box. So just click.
You can always go to any one of your primary care physicians.
Yes.
To get checked out, to get a referral. So therefore, because some insurances are going to ask you for a referral before you go somewhere. So we got to play the game with the people with the insurance.
Right.
So
we hate it as much as you do.
Right. So it's just making sure you get that referral and that prior authorization, and just make sure everything else goes through. But there's plenty of places for you guys to check out. Like Joe said, TMH websites below. You can go to our website and find out. You can contact me and Joe. You can contact TMH. You can find out anywhere. Google, find out, reach out to us, and that way we can make sure that you live normal, healthy lives. That's our main.
Right. So our final question, and I've thoroughly enjoyed this.
Me too.
Thanks. So
I really like that robotic stuff.
You'll have to come and visit. Go watch a surgery.
Right. So what tips would you give to our audience, male and female, to better help prevent and or treat the different gynecologic cancers as we move forward into the future?
So screening is key. That absolutely see your doctor. I know, a lot of people are really hesitant, especially in our current climate because of COVID. And I want people to be assured that, we take that very seriously. We're screening for that as well. And that shouldn't be a reason why you don't get seen. It was, we had COVID, unfortunately, is probably not going away anytime soon. And so we've learned to adapt and continue to provide the care patients need in this environment. And so be seen, have regular checkups, openly communicate with your doctor. Don't hesitate to tell them things. They can provide better care for you. And I assure you, there's not anything you could say that would shock them. We have heard it all. And as I said earlier, it's a judgment-free zone. So keep that communication open, because their primary objective is to care for you. And the more information you can give them, the better they can do that.
Go. Screenings. Look, here in Neighborhood Medical Center, especially our Ryan White team, prevention is our favorite word. Mm-hmm. So we want to get it before it happens. So somebody watches this podcast, TED Talk, CNBC, Fox News, who knows, all the grand platforms, and they say, you know what, I really like Dr. Amanda Stevens. How do they get in contact with you?
You would go to pr@tmh.org. If you shoot them an email, they can get you hooked up.
Okay, and say ER@tmh.org.
PR, public relations.
Yeah. Okay,
PR@tmh.org.
All right, and that way, be able to get in contact with us, because you're doing amazing work at TMH. And I like to say this because I'm a native Tallahassee, and anytime people come to my city and pour into my city and give their all to my city, to the betterment of my city as a native Tallahassean, I want to thank you, because You could have gone anywhere, could have done anything, but you decided to come here, and not just come here and just be average, but you are thinking outside the box and being innovative and really going above and beyond to help all of the patients and all the people of Tallahassee. So definitely want to thank you for that.
Thank you. It's really my privilege.
Yes, ma'am. So look, I told you this is the greatest health podcast in the world. And this conversations like this are why you need to make sure you're tuning in, sharing this podcast with other people. Tell a friend to tell a friend to tell a friend to tell a friend. And you all get together and you watch Mind Your Body and Soul. And remember, we are an educational podcast that focuses on all things health related to help our listeners learn more about the health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, every Wednesday, or just about every Wednesday, www.nmcpodcast.com, Neighborhood Medical Center on YouTube, as well as Anchor, Breaker, Radio Public, Pocket Cast, Spotify, and Google Podcasts. So with that being said, once again, thank you, Dr. Stevens.
Thank you.
Thanks for having me.
No problem. I am Joseph Ward. He is Matthias Sweet. This is Mind Your Body and Soul, and we'll see you next week.
All right.